Hi, good evening everyone. My name is Dr. Koythong, and again I'll be talking about alternatives to hysterectomy and the different routes of minimally invasive surgery, or MIS, that we perform here at the Pavilion for Women. So when a patient typically comes to us for evaluation or consultation for pelvic pain, it's not uncommon for them to have had see multiple doctors or multiple providers for several months, years before coming here, and having been told that perhaps a hysterectomy is necessary to alleviate them from their pain. And that's presuming a gynecologic cause. And a lot of times we get questions, is this true? Do I absolutely need a hysterectomy? And my response to that typically is, depends on what's causing your pain. If during the course of your evaluation we find that the uterus is not a major trigger of your pain and we proceed with a hysterectomy, obviously we've done a major surgery sterilizing you without completely addressing the other causes of your pain. So typically when I evaluate a patient, I'm trying to see what symptoms that you have that may kind of point towards other causes rather than the uterus for your pain. So that typically involves a very in-depth pelvic exam, which may be a little bit more nuanced than pelvic exams you've had with other providers or gynecologists. Because I'm trying to see if perhaps your bladder is involved in painful bladder syndrome, like Dr. Orway alluded to, vaginismus or vulvodynia, which Dr. Khan alluded to, any potential fibroids, like Dr. Nassif alluded to, adenomyosis, things like that, because doing a hysterectomy or removal of your uterus in those syndromes obviously is going to treat that pain. So I'm also going to be feeling your bladder, your pelvic floor muscles, the uterus itself, and a lot of times during my evaluation I also do a rectal exam, because in evaluation for endometriosis, which is what Dr. Guan will speak about later, in very severe cases can involve the rectum, and I'm trying to see if we proceed with surgery, if we need other surgical subspecialties involved. Another consideration for hysterectomy is, a lot of our patients are in their early 20s, their 30s, their 40s, and they're still wanting to build or continue to build their family. Doing a hysterectomy will effectively sterilize them, and obviously you're not able to carry a pregnancy yourself. So there could be alternative options depending on the pathology that we identify that will allow you to maintain that fertility. Other considerations against hysterectomy: if a patient decides to proceed with surgery, they may not want something as invasive. A hysterectomy is a very drastic surgery. It has typically a longer recovery. Even though we strive to perform any surgery here at the hospital in the most minimally invasive fashion possible, a hysterectomy, if you do proceed with that, is still a major surgery. It's not without risks. And you do have the risks of longer anesthesia and a longer operating time. And along the same line, typically patients also want to have a procedure with the quickest recovery, and sometimes a lot of patients have a lot of personal work stressors, and they're trying to schedule something, a treatment plan or surgery around childcare or work. So what are these other procedures or treatment options available for you if you don't want a hysterectomy? Again, it depends on the pathology that is identified. So if you have a fibroid on either exam or imaging, you can remove just that fibroid itself and leave the uterus in place. And this can either be done laparoscopically, so incisions in your abdomen with a camera in the pelvis, which I will show a picture of later, or hysteroscopically with a camera inside the uterus and this really, the approach depends on where the fibroid is on the uterus itself. If during the course of the evaluation we find that you have cysts on one or both of your ovaries, we can remove just the cyst itself, preserving the ovaries and the uterus. And as well, during the course of the evaluation, we find or suspect that you have endometriosis. Of course, removing the endometriosis and that disease while preserving your uterus will also avoid a hysterectomy. Pelvic floor physical therapy, as Sarah will kind of discuss after me, is something that I use very frequently in my patients because a lot of our patients have some sort of pelvic floor dysfunction as a result from suffering from pain for quite a long time. So I utilize that a lot. So now you've made the decision that you want surgery. What goes into our thought process and our philosophy and how we decide what surgery to have? So we, of course, have to take the whole clinical picture into account. What exactly are we treating? Where is the pathology that you have and how do we access it? And then particularly in our endometriosis cases, what other surgeons do we need at the time of surgery? So again, in very severe cases of endometriosis, you can have that disease affecting your bladder, your ureter, which is the tube that connects your kidneys to your bladder, the rectum, sometimes the diaphragm. So a lot of times you can have either a urologic surgeon, a colorectal surgeon, or a cardiothoracic surgeon involved in those cases. And how we approach surgery also depends on those surgeons' preferences for their approach to surgery. So briefly, just the different approaches that we offer here. So the first one is hysteroscopy, so placement of a camera inside your uterus. So this is a picture where you have the hysteroscope, so basically a camera that you introduce through the vagina and into the uterus itself. This procedure, as it relates to pelvic pain, I would say the most disadvantage to that is that you can't really evaluate the pelvis because the camera is only really looking inside the uterus itself. So this is best and the optimal route of surgery if we feel like the cause of your pain is within the cavity of the uterus itself. So that could be a fibroid in a submucosal location, so within the cavity of the uterus. Or sometimes you can have a foreign body like an IUD that's malpositioned, sometimes can be embedded or stuck within this thicker muscle wall layer of the uterus. Next we have traditional laparoscopy. So again, this allows you to evaluate the complete abdominal and pelvic cavity. So this is just a little diagram of what it looks like when you're undergoing surgery. This typically involves the use of about 3 to 4 half-centimeter incisions, and through these incisions we insert different instruments and the camera. And through these incisions, there's a TV screen in the room, and then we're able to look at pictures itself. We also use gas, during this surgery. So we basically distend the abdomen with carbon dioxide, and that allows us to create more space to operate and to see, and that gas is eventually suctioned at the end of surgery. As well, we have robotic-assisted laparoscopy. So still laparoscopic surgery. You can see there's typically a surgeon console where the surgeon operates and controls this robot that you see here remotely through the use of this console. This robot here, there's typically 4 arms involved in this console, and these arms are docked or connected to basically robotic ports or trocars that have been inserted in the patient themselves. So this console essentially has some advantages. So the actual robotic instruments themselves allow for improved dexterity and fine motor control. The camera used in the robot allows for enhanced 3D visualization. So this allows for our surgeons who use this platform to do a little bit more finer dissection compared to laparoscopy, because your instruments also have 360-degree range of motion. I like to use this a little bit more for my endometriosis cases where that finer dissection is necessary, as well as my myomectomy, so removal of the fibroids, because sewing the uterus afterwards can be done a little bit more quickly to mitigate blood loss during surgery. The other approaches that I spoke about are multi-incision. So we also have single incision laparoscopy available here at the Pavilion for Women. This involves the use of 1, 2.5 to 3 centimeter incision, and this is typically done at the belly button or the umbilicus because that's the most aesthetically pleasing. You can hide that incision a little bit better. This can either be done through traditional or laparoscopic, robotic-assisted laparoscopy. So this picture up top is a picture of the port that we use, and the reason why this incision is larger than the 5 to 8 millimeter incisions is because we use this one incision to put multiple instruments within that one incision. This is a picture of those ports, so you can see a total of 4. So here's one, here's another, Here's another, and here's the fourth. This is through the use of the robots, so you can see that the robots are docked at these trocars right here. Sometimes with single incision laparoscopy, you can still have an additional 5 to 8 millimeter incision either on your lower right or your lower left side, but it's kind of minimizing the amount of multiple incisions compared to essentially multi-port laparoscopy. We also have a complete transvaginal surgery. So the advantage of this is that there are no abdominal incisions. All the incisions are in the vagina. This surgery is done completely through the vagina. So this is a picture if we're looking at the pelvis during the surgery. So a retractor basically has been mounted at the vagina. And these instruments right here are essentially trying to push away the vaginal wall and create more space to operate and to see. Typically, when we do this type of surgery, an evaluation of the pelvis can't be performed because you can imagine there's a very small opening that you're working through and you can't see completely into the cavity itself or evaluate the upper abdomen, but you do have no abdominal incisions. So the combination of laparoscopy and vaginal surgery is vaginal natural orifice transluminal endoscopic surgery, which is a handful to say, or V-notes, and the man sitting on the far left of the table is one of the pioneers of this surgical approach. It's very niche though, so I will say there are probably only a handful of surgeons within the United States who do this surgery with some sort of frequency, and this can be done either laparoscopically or with the assistance of the robot. So I think Dr. Guan is still the only person in the United States who's doing this through the robotic-assisted approach with any sort of volume or at all. And it's very nice because, again, the benefit is that you don't have any abdominal incisions. With the robotic camera or the laparoscopic camera, you're able to insert the camera through the vagina and put the camera a little bit deeper in the pelvis and kind of evaluate the entire pelvis and the upper abdomen. So this, again, is a picture of the robot. So there's a port that is placed near the vagina. These instruments are going through the vagina. This is the camera that allows us to see. And this is just a little diagram of traditional laparoscopic V-notes, so not the robot. And then here's your camera and your instruments that go through that port. So just a brief takeaway. So the decision to proceed with surgery and what exactly it entails should be an ongoing discussion between you, the patient, and the physician. Both the physician and the patient should be comfortable with the plan that is made, and I think that's very paramount. There are many routes of surgery available, as I alluded to, and even amongst the people who are operating on the panel, I would say have a different distribution of types or the routes of minimally invasive surgery that we perform. So I would say, and correct me if I'm wrong, Dr. Guan does the vast majority of his surgeries through robotic-assisted single incision laparoscopy or robotic-assisted V-notes. Dr. Nassif mostly does multi-port robotic laparoscopy. Dr. Uruwela is a genius and a guru of transvaginal surgery. And then I would say I'm mostly multi-port robot or traditional laparoscopy, and I do some robotic-assisted single incision laparoscopy as well. And that's all I really have. Thank you for your time.